Hello everyone, I hope you are well today. I am Dr. Zsolt Zsákai. I work in Hungary as the Deputy Chief Physician of the Orthopaedic Surgery Department of the Borsod-Abaúj-Zemplén County Central Hospital and University Teaching Hospital in Miskolc. In this video, I shall give a detailed, easy to understand, honest and comprehensive picture of hip replacement surgery to patients and other interested parties. I wish to point out that the content in this video cannot be considered equally applicable to everyone. If you have a complaint, I strongly recommend that you consult your own orthopedist, who will provide you with the appropriate information, treatment, and the surgical advice, presumably tailored to your individual needs. I hope that you will find useful information in this video. Let's get started then. It's perhaps not a maxim, but it's actually true. Everyone wants to live free of pain. Pain is one of the most impeding factors that can make everyday life difficult for us humans. Perhaps you may already know that prosthetic replacement of the hip joint can resolve pain caused by wear and tear of the joint, which is why it's currently an accepted method to improve the quality of life. Roughly 800,000 hip replacement surgeries are performed in Europe annually, while in Hungary the number of implantation is estimated to range between 12,000 and 15,000 per year. This number increases by an average of 15% annually, and when evaluated by individual countries, this growth rate is variable and shows a seasonal distribution. This is an extremely high number. Let us continue by examining the reasons that may result in wear and tear of the hip joint, and then describe the available information on hip prosthesis. Symptoms and treatment of hip joint wear and tear. Wear and tear of the hip joint is a complex condition causing typical symptoms that can be classified into two main types. Primary wear and tear actually develops as a result of the aging of cartilage. Secondary wear and tear always develops as a result on some triggering factors. The causes may include trauma affecting the hip, inflammatory conditions, tumors, metabolic diseases, the consequences of childhood hip disorders, developmental disorders, poorly treated or untreated hip dislocation, hip impingement syndrome, also known as femoroacetabular impingement. Common symptoms. It is characterized by pain radiating into the groin, buttocks, and thighs. As the process progresses, the pain at night increases and becomes constant. Later, the pain becomes associated with and increasing upon physical activity, and finally it becomes permanent. Walking becomes difficult, and patients complain of a limping gait. Numbness in the lower limb is less common, and in such a case it's always a good idea to look for other reasons for the complaints. Establishing the diagnosis. The right specialist can almost instantaneously diagnose joint cartilage wear and tear with a physical examination. Naturally, it is proper to assess and confirm the diagnosis objectively or in a manner that can be demonstrated to the lay patient. In this regard, X-ray scans play an important role, providing a clear picture of the expected stage of the disease, while also providing assistance in planning the surgery. For more complex lesions, CT scanning may be warranted, and CT scans with 3D reconstruction may be of special assistance to the operating orthopedist. Treatment. The first step in the treatment of hip joint wear and tear is prevention. Unfortunately, a lifestyle rich in appropriate forms of physical exercise, providing optimal load bearing for the joints, together with a proper diet and body weight control, though essential, may not be enough in some cases. Their preventive role is indisputable because they can delay the onset of wear and tear and can even do it effectively. Based on cartilage physiology, joint movements improve cartilage metabolism. Moreover, moving a diseased joint has an analgesic effect. We take advantage of this with the help of physiotherapists who can assist in providing pain relief and preserving range of motion. It is important to note that in the case of advanced wear and tear, this effect is already small and may even increase complaints due to the overloading of the one joint. Therefore, beyond a certain stage of the disease, the physiotherapist must also recognize the need to proceed with other treatment options. Knowledge of the different types of hip prosthesis and choosing and using the proper implant type is the orthopedic surgeon's job. A well-trained orthopedic surgeon is unlikely to make major mistakes when choosing the proper prosthesis. The type of prosthesis is chosen for the patient's being, with a bit of exaggeration, tailored to the individual. Thus, the prosthesis chosen for an older patient in poor general health, where hip replacement becomes indicated after a femoral neck fracture, should be different from that chosen for a patient in good general health or of a younger age. Nowadays, total hip endoprosthesis has become the international standard of care for patients in suitable condition and of a proper age. Lay people have become increasingly aware of the existence of cemented and uncemented prosthesis. The essential part of hip replacement surgery is carried out the same way in both cases. The two techniques differ when the decision is made whether to use a fixed prosthesis. For the cemented type, the prosthesis is embedded and fixed by a bonding material called bone cement, while for the uncemented or cementless type, the surface of the prosthesis is coated with a material that gives it a porous surface structure, and after implantation, the bone shall grow into these microscopic channels, and ultimately this bony connection shall ensure proper attachment. It is a misconnection among patients that one particular type shall be more beneficial for them. By all means, the method should be individually tailored after a proper assessment of the patient, based on the knowledge of the case and X-ray findings. Rehabilitation after surgery is also different for the two types. According to the general principles of rehabilitation, the affected leg may bear loads 6 weeks after the implantation of a cementless prosthesis and 2 to 6 weeks for a cemented prosthesis. However, the most recent professional guidelines allow for less strict protocols. In my opinion, it is the responsibility of the operating hip surgeon to decide on the pace of rehabilitation, since they saw, felt and palpated the quality of the bone during the surgery, and based on this, thanks to their proper professional experience, they can give an opinion on the extent and time needed for avoiding loads. With the development of surgical techniques and accumulating experience, the so-called muscle sparing, without muscle transection, hip replacement surgery performed in an anterior approach has become increasingly popular. It is also called a minimal invasive intervention, though in my opinion this is not entirely true. I myself use this technique when implanting a primary hip prosthesis, and I have also switched to this technique in cases where replacement of the prosthesis is warranted. Anterior approach refers to a technique which is performed via an incision of about 8 to 10 cm or 3 to 4 inches made on the frontal part of the thigh at the level of the fold of the groin without muscle detachment. Compared to traditional surgical explorations, this is advantageous for several reasons. Post-surgical pain is present for a shorter period of time and often it is milder. Recovery time is reduced. Mobilization can be accomplished faster after surgery. Thus, the duration of rehabilitation is shortened. Less blood loss can be expected, and aesthetically, the surgical scar is smaller and can be more easily hidden for patients sensitive to this issue. The probability for hip prosthesis dislocation can be reduced, and also the limb length can be adjusted more easily. The surgery can be performed in almost all people regardless of their body type, though it should be added that for certain body types, hip replacement surgery may be more difficult. During patient assessment, especially after viewing X-ray images, the surgeon is already considering the technical challenges that may be expected during surgery. This approach can be referred to as the so-called bikini incision approach, which may be requested by ladies who arrive for the appointment already aware of this option, or the surgeon can introduce it to the patient when discussing information about the procedure. How long does the surgery take? In skilled hands, with the right technique and with the cementless implant, it takes 35 and 45 minutes on average. Of course, it may take longer if the surgical situation requires it. How long will you need to stay in bed after hip replacement surgery? After 24 hours, the day after surgery, individualized rehabilitation should begin, and thus, if the patient's general condition allows it, the load bearing of the limb may begin. Choosing the pace of rehabilitation should be a joint effort of the physiotherapist and the operating surgeon. What kind of preoperative investigations may be necessary? In general, ear, nose and throat, dental, laboratory, angiological, cardiological and gynecological or urological examinations are performed, but depending on the risk factors identified in the medical history, individualized examinations may be necessary. Their importance cannot be overstated. During the evaluation, adequate or normal findings significantly reduce the risk of complications, while the opposite is also true. Inflammation, laboratory abnormalities, cardiological problems or blood pressure issues found during the evaluation significantly increase the risk. Is there any pain after surgery? The short answer is yes. The longer answer is, of course, there is. Any surgery performed on bone can be associated with significant pain. However, from an anterior access and without massless separation, rehabilitation time and the duration of post-surgical pain can be significantly reduced. The role of physiotherapy here is essential and indisputable. One thing is certain. Even with the latest techniques, we cannot promise to eliminate pain during the first few days after the surgery. The good news is that with adequate pain relief therapies, this period can be managed, and once it is over, many, although not all, people experience a significant improvement in their quality of life during the early post-operative period. What is the age limit for performing this procedure? The truth is that your age is not the most important factor. Your general condition is. If no high-risk disease is revealed during the evaluation, and the patient is in good general condition, the surgery can be performed. However, it is definitely useful to know that the burden placed by the surgical procedure and its effects on the body are more demanding for older people, occasionally causing an unexpected deterioration of the patient's condition. It is important to note that age can be a limiting factor for surgery performed in a private institution, as the risk is higher and most private clinics should not assume this greater risk. However, when a case is rejected, it should be assumed that it is done in the interest of patient, since the goal is to avoid creating a complication or a poorer condition. Life after prosthesis implantation. Hip replacement surgery can be expected to significantly improve the quality of life of the patient, making, for example, work, cycling, even using an indoor exercise cycle easier and complaint-free. Walking, hiking, and climbing stairs may also be reintroduced to your everyday life. Driving a car can also be made a daily routine with a little attention. Of course, there shall and should be limits. Crossing your legs is never allowed after your hip replacement surgery because the likelihood of dislocation increases. The same applies to sitting in a very low chair or bending your hip at a sharp angle. It is not advisable to carry heavy objects, so to avoid overloading the joint and consequent loosening of the implant. Despite the horror stories that sometimes appear in the internet forums, the following complications should not frighten patients and other interested people. However, it will be foolish to think that everything always turns out for the best for those living with a hip prosthesis. Nowadays, intraoperative during surgery and post-operative after surgery complications largely fall within an acceptable range. But unfortunately, it is also important to point out that in the event of a complication, we are on a one-way street with nowhere to go but forward. The treatment of the complication through a series of appropriate professional decisions should then bring a cure. Severe complications are less common, but they also have a negative impact on quality of life. Avoiding them is the joint responsibility of the operating surgeon and the patient. Intraoperative complications. Development of hematome, cardiovascular complications, blood vessel injury, nerve injury, bone fracture, muscle injury, and embolism. Overall, these complications do not occur at a high percentage. However, you should be aware of them and their risk when you agree to an intervention like this, since these complications may influence the outcome of the surgery and may lead to long-term effects, reduced quality of life, or even severe consequences. Infection. According to international literature, the incidence of infections is about 1%, which is considered quite rare. Diabetes and liver diseases increase the risk, and infectious diseases occurring in other parts of the body also play a role in the development of periprosthetic infections. Dislocation. Prosthesis dislocation, or popping out as patients call it, occurs in about 4% of hip prosthesis. Symptoms of dislocation and loosening. The average lifespan of a hip replacement is 15 to 17 years. During this period, later if you are lucky or sooner if you are less lucky, the body begins to push out to reject the prosthesis. Actually, this is a protective reaction of the body against the foreign material. In fact, sterile loosening and dislocation of the prosthesis is considered the most common long-term complication. Attending regular checkups with the operating surgeon or scheduling them earlier in the event of symptoms can provide a suitable time window to plan and carry out the replacement of the prosthesis under better conditions. Changes in limb length. The most important factor when implanting a hip prosthesis is to ultimately achieve stability of the artificial joint. From this perspective, limb length may sometimes need to be changed, and occasionally adequate stability may only be achieved using a prosthesis with a longer component. The risk of this complication may be reused with an anterior muscle sparing technique. In the case of insufficient stability, we increase the risk of dislocation, which, believe me, is not a desirable complication. By using a thick insole or by raising the height of the shoe, the problematic length difference can and should be corrected. One of the most important statements here: prosthesis implantation is not plastic surgery, and it should not be considered as such. Thrombosis. Nowadays, prophylactic antithrombotic agents are used routinely by orthopedic departments during lower limb surgeries. However, development of thrombosis may still pose a real risk. Periprosthetic fracture. The incidence of fractures adjacent to prosthesis is about 1% for primary implantations and about 4% for revisions. Such adverse fractures sometimes require major interventions and complex surgical solutions. However, effective healing may be achieved with a proper organizational, professional, and technical background. Blood loss. Bleeding from large blood vessel injuries or following surgical exploration, given the nature of the intervention, may occasionally lead to severe blood loss that is demanding on the body. In such cases, hematopoietic drugs, transfusions of the patient's own blood, or matched donor blood transfusions are administered according to strict professional rules. Numbness. A rare complication is extensive sensation and movement disorder affecting the entire limb. There may be skin areas of temporary or very rarely permanent numbness around the scar or in certain parts of the thigh. The regeneration time of the skin's nerves may range from a few months up to 18 months. Physiotherapy, selective stimulation, current therapy, and TENS therapy can speed up the recovery. I hope that you have found this summary useful. If so, please feel free to like and share it, and subscribe to my channel where I plan to post regular content. Should you have any questions, please don't hesitate to make an appointment online or in person to my private practice, where I will be happy to assist you. I wish you a great day. Goodbye.